Hi everyone, this is Sam Robinson from the BCCSU. I see that it's 5:03 and that a number of folks have joined us. We may expect others to trickle in over the next few minutes, but just wanted to welcome you and say hi, and we'll get started shortly. I thought it would be helpful to go through some housekeeping items in case folks are new to using GoToWebinar. So first, this is going to be an interactive session, so we'll encourage your participation. And most of our time is actually going to be dedicated to a panel discussion, and we really want to hear from you. So if you could type your questions in or use the raise your hand function, we'll try to get to as many questions as we can in the second half of the webinar. Also, we'd like to learn a little bit more about who's joining the webinar. So we'll be polling the audience. There's only 5 questions, so please select or type in your answers as the questions appear, and this just helps give us an idea of who joined and who's participating. So I'm going to just start the polling now, and that should only take a minute or two. So you'll see some questions come up, and if you could respond to them, we'll go to the next question. And this just helps us with some tracking and for our evaluation purposes for these webinars that we've been hosting. Okay, and I'm going to launch the next one. So I'm going to do the first 2 now, and then we'll do another poll kind of after the first presentation, just to make sure everyone's still awake and to keep people on their toes. And to not take up too much time at the beginning here, but thank you all for adding in your responses. We're getting really good response rates, so really appreciate you taking the time to do that. Perhaps now I'm going to share my screen and we can get started. So welcome everyone. If you've dialed in, you'll know that you're joining a webinar co-hosted by the Harm Reduction Nurses Association and the British Columbia Centre on Substance Use, titled Innovative Approaches to Keep People Safe in the Context of COVID-19 and the Overdose Crisis, the Role of Nurses. And I'd like to start by just briefly introducing the moderators. So that's me, Sam Robinson. I'm the Interim Clinical Director at BCCSU, and I'll also be co-moderating with Mary Lou.
Hi everyone, my name is Marie-Lou Gagnon. I'm an Associate Professor in Nursing at UVic, also scientist at the Institute for Substance Use Research, also known as CSER, and the President of the Harm Reduction Nurses Association.
And we just like to start with a land acknowledgement. So for myself, I'm currently in Vancouver and respectfully acknowledge the land on which I work, which is the traditional territory of the Coast Salish people, including the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh.
And this is Marie-Lou. I'm located in Victoria, also known as the land of the Requangran peoples and the Songhees Esquimalt peoples, whose historical relationship with the land continue to this day. And I feel very fortunate to be welcome here and working here.
And we just acknowledge that we know others are joining from other parts of the province and elsewhere in Canada. So just take a moment and consider where you're working and just want to acknowledge that we're all able to do our work because of how well the land's been cared for over many generations by Indigenous peoples. So for today's webinar, this is a brief overview of what we'll be covering. So we just did our quick introduction for the moderators. We're going to be going through a quick presentation on some of the risk mitigation guidance, as well as some panelist introductions, and then we'll have plenty of time for question and answer for the panel. So this is when we'll ask you to raise your hand or type in questions into the window, and then we'll do a wrap up. So if at any time there's technical issues, please just type into the chat as well. We just want to make sure that you can hear us and see what's on the screen. So maybe I'll move right into the presentation. So we thought it would be helpful just to kick off this webinar with a brief overview of the risk mitigation clinical guidance, which is interim guidance in the context of dual public health emergencies. And we thought it would be really great to talk a little bit about, at least how this guidance has been developed, and then follow through with a discussion about some of the challenges in implementing the guidance, and specifically thinking about nursing roles, both with respect to this guidance work, but also more broadly in the context of the overdose crisis and the COVID-19 pandemic, and how those two public health emergencies are intersecting and compounding risks and challenges for people who use drugs. So this little presentation, we're going to overview some background and context for the guidance, talk a little bit about what's actually included in the guidance document, and then, as I mentioned, overview some challenges and opportunities, as well as some specific highlights on what nurses can do in their roles as it pertains to this work. So folks will know that early in March, the WHO declared COVID-19 a pandemic, and about mid-March in BC, it was declared a public health emergency. And we know that this pandemic really increases a number of risks for people who use drugs. So both risk of infection and spread of infection among those with underlying health conditions and who face social marginalization, as well as risks due to withdrawal for those who must self-isolate, as well as ongoing risks for overdose and other harms. So here's what the new guidance looks like. It's available on our website. It is interim in nature and is not meant to be considered treatment. So in an effort to reduce many of the risks I just discussed, the BCCSU worked with regional and provincial partners to develop interim clinical guidance that would support folks at risk for withdrawal during physical distancing or self-isolation. And again, this is not really considered substance use treatment, but more pandemic prescribing, as we're referring to it. So how we can support people to stay in self-isolation and stay safe in the context of the emerging COVID-19 pandemic. So our eligibility criteria included people at risk of COVID-19 infection, which is pretty broad, those with a confirmed COVID-19 positive or suspected case, history of ongoing active substance use, and folks who are at high risk of withdrawal, overdose, craving, or other harms. And we worked with a very large group of authors and reviewers, building off a lot of work that started at Vancouver Coastal Health with a team of clinicians there, including a number of addiction experts who really led the development of the protocol and some of the clinical aspects of this document. So the guideline development process included exploring literature and also our own clinical expertise in injectable OET, tablet injectable OET, managed alcohol programs, and nicotine replacement. We also explored unpublished research from Vancouver that showed that illicit hydromorphone use decreased illicit fentanyl use. And there's ongoing work in collaboration with the VCH to develop safer supply guidance. So this all was happening at the same time as some of this underlying safer supply guidance work as well. We also did a lot of consultation with regional addiction leadership, people with lived and living experience of substance use, and the health systems partners we were going to work with to implement this. So just as a brief overview, these are some of the medications included in the guidance. Really, acknowledging that there's evidence in the literature and clinical experience in prescribing hydromorphone, nicotine replacement, and managed alcohol, but for others, like prescribing stimulants, the evidence is not as well established. And so we really are relying on clinician judgment when it comes to prescribing some of these medications. So now I'm just turning to give people an idea of, in initially designing this guidance, what we thought the ideal pathway to access these medications and to support people would look like. So the patient would contact their primary care provider, they'd collaboratively develop a care plan, a prescription would be written if appropriate and faxed to pharmacy, pharmacy would fill the prescription, and then there would be a continuity of care that would continue with the primary care provider, and the refills would be managed by the pharmacy and prescriber, and the cycle would continue during the pandemic to keep people safe and be reassessed as needed. So we know that there have been a number of challenges, some of which are outlined here. So for example, a number of patients who might really benefit from this guidance don't have a primary care provider. For a long time, I would say, what feels like a long time, maybe 6 weeks, there's been a bit of an unknown pathway to access for patients and for families and for advocates. So how to know, depending on where you're living, how you could actually access these medications, who it's safe to talk to for folks that don't have a primary care provider. So that was kind of an ongoing barrier that we're working to address. And also, in the current context, having the rapid access addiction services, we thought is a real place to help people connect to care, but acknowledging that in the context of people working remotely, some of these services were nearing capacity. Some other challenges, having primary care providers that are uncomfortable prescribing these medications, thinking about other care plans that could be developed, like optimizing OAT, and acknowledging that there's a small group of physicians and nurse practitioners already in the province that do OAT care and care for addictions in general. And so, the uptake of this guidance, it's not surprising that it was low, given that. Also, I'd say, oops, I realized I went back. 1 second. Another piece is challenges at the pharmacy level. So seeing a really, a large amount of hydromorphone being prescribed, and challenges of hesitation around filling a prescription like that, and just delivery capacity challenges, and in rural and remote settings, thinking about the limited number of pharmacies that could be engaged in this work, and thinking about other ways to get the medications to patients, even if they were prescribed. This slide just talks a little bit more about some of the implementations I already mentioned, but I think one of the things that's really important to acknowledge is that we really do have a lack of a functioning addiction treatment system. And I think some of these challenges were highlighted in the attempts to implement this guidance. So as I mentioned, there's a limited number of skilled substance use and addiction providers, and we really rely on people having knowledge in this area to do this work. As I mentioned, there's an inequitable access across the province in terms of where people are living, and if you're in a rural and remote area, you may only have one primary care provider that you can access. So thinking about what are some creative or innovative strategies to support people. As well, I mentioned for healthcare providers specifically, the feeling that the responsibility for this work was downloaded to MDs and NPs, and it really does rely on having a prescriber that's willing to do this work. And I think there's a lot of other pieces that need to be considered when doing this work as well. So wraparound supports, not every community has an intensive case management team, for example, that could do outreach and support people in the long term and helping people continue to access care. And so I think, there are complex issues that probably require more wraparound support, and not every primary care provider has that at their disposal. Existing barriers to accessing OAT have been amplified, and as I mentioned before, on the pharmacy side, some of the pieces around delivery have been especially challenging, and stigma. So what are some opportunities through this work? I think we've really leaned on and been really fortunate to have a really strong peer network throughout the province, as well as family advocates and people that are really willing to step in and support others trying to access medications and do their best to really help make up for some of the system challenges mentioned above. The regional health authorities have continued to explore and look for other avenues for access, where that might be, a call line or other services to really support, quick assessment and connection to that primary care provider for people that don't have one. So I think it has required a lot of creativity and innovation. Also exploring additional delivery options. So we think about rural and remote settings. We know nurses already play a leading role in this. And connect people, especially in rural and remote settings. We know that nursing professionals are screening and facilitating a lot of those connections to care, as I mentioned. And another opportunity, I think, is really considering what the post-COVID landscape is going to look like and starting to do some planning and ongoing work to explore how this guidance might evolve and what a future state might look like. So just coming to my last couple of slides, wanted to really point out, and I think this is some of the material we're probably going to dive into in more depth with our panel discussion, but really what are some nursing opportunities that exist in this space, thinking about how to support people in both accessing addiction care and also staying safe in the context of COVID-19. So what are some tangible things that nurses can do? Well, talking with your patient about accessing this kind of pandemic prescribing that might fit their needs and health goals, I would say, as well as looking at where people can optimize their OAT. So if people are already on OAT, maybe there's more information that the nursing staff can glean around how that's working for people, or where we might be able to make some changes in their OAT management to improve their care. Things like motivational interviewing, brief interventions where they're appropriate, connecting patients, so being that conduit to support people in accessing substance use care. So that could mean medications, but it could also mean other outpatient supports, recovery services, really working with people to determine where they're at, where they want to go, and helping to make those connections. As well, I think we've learned in this context that nurses do support a lot of challenging conversations. So for example, many challenges that people have faced in accessing care. So when pandemic prescribing might be the right option, but patient really needs an advocate and needs some support in accessing care. That might mean finding a different prescriber and working within the confines of the system to help support someone getting access. Could also mean having a challenging conversation about, a time when pandemic prescribing may actually not be the right option and may put people at increased risk. So I think, nurses can really play a pivotal role in they often know a lot about patients and they know what's going on and can have those conversations and support people. The other piece is outreach and delivery. So there already are federal exemptions that apply to nurses in terms of transporting controlled drugs and substances. And so utilizing that where possible to help connect people specifically to medications. Also, thinking about how you could support your own team in the development of post-pandemic planning. So, if someone is using this pandemic prescribing, like what will the context look like after COVID, and where, how are we going to make sure that that patient has continuity of care and can get connected to long-term care in the future. And the other piece that I think as nurses, we are often doing a lot of the day-to-day heavy lifting work clinically, but I think there is a real role for nurses to advocate for and support, evidence-informed policy, specifically in your area of practice. And so a lot of times I think we just don't have the time to do that, or it's not perceived. There's so many other things going on, and but I think this is a really important role that nurses often play. And I think, Mary Lou can probably speak to this too, but I think it is really an important piece, especially having the knowledge of working with patients day to day and really seeing the challenges that people are facing and where you can advocate for policy change within your institution and also at the higher level. So just drawing your attention, this is a pretty busy slide, so I apologize for that. Just wanted to draw your attention to a number of resources available on the BCCSU webpage before I close out this portion of the webinar. So all of these can be found at bccsu.ca/COVID-19. So we have a OAT bulletin that really looks at providing opioid agonist treatments, and this is targeted toward prescribers and pharmacists, but I think still really helpful in the context of this webinar and thinking about the advice and the guidance that we are putting out, and supporting nurses to have those conversations, as well as NPs. The risk mitigation guidelines, which we've talked about here. We have a bulletin on alcohol use disorders and withdrawal management, which is largely kind of a summary or a quick guide to our larger provincial alcohol use disorder guidance, and specifically in the context of COVID-19. We've developed a patient postcard and poster that are available that help give some information on, how to have those conversations with providers. And I'd say coming soon, we have an operational guidance document. It's a collaboration between BCCSU and CSER, as well as a document that'll explore harm reduction strategies for injecting tablets, and that's some collaborative work between BCCSU and BCCDC. And I'll leave this up for a second as well. So there's a number of other resources folks can access on our website. And with that, I will close and turn it over to Mary Lou, who's going to facilitate the panel discussion.
Thank you. That was a really great overview, Sam, of a lot of content that you managed to squeeze in a few minutes. We want to keep as much time as possible for questions for our panel, because we have a very experienced panel, and we're very lucky to have 4 people today joining us with tremendous expertise and also on-the-ground experience of implementing these guidelines, or close to these guidelines, pre and post-COVID. So we're joined by Corey Ranger. Sorry that the Francophone in me wants to jump in here. And Tim Gauthier, and I'll let them introduce themselves very quickly, and Megan Tumath and Guy Felacella. And if you don't mind, each of you just kind of stepping in, maybe in order. We'll start with Corey, and just making sure I'm going to unmute you, Corey. If you can just briefly introduce yourself, and maybe just to start a conversation, because we already have a question lined up. And for those of you who have your burning questions, this is the time to type them in the question box so I can read them out loud. So maybe Corey, if you want to briefly introduce yourself, your current position, and your experience in terms of supporting people during COVID and what you've been doing.
For sure. Can everyone hear me all right?
Yes.
Good. I'll assume yes. And if you hear whining in the background, it's because my dog has an upset stomach and has chosen to lay right next to my feet. So it's not me, it's the dog. My name is Corey Ranger. I'm a registered nurse. I spent most of my background career working in Alberta, focusing on take-home naloxone, supervised consumption services, bloodborne pathogen programming across Edmonton, Calgary, Brooks, and Medicine Hat. I returned to British Columbia last year and took on the role as project manager for BC Campus, responsible for the provincial peer training curriculum project, which has been an amazing experience connecting with a lot of people with lived and living experience and supporting them to develop training materials. Kind of how this whole process started out for me was I also on the side do webinars for HSABC about harm reduction. And when COVID really started to take hold, I was asked if I would do a webinar about COVID precautions for people who are working on the front lines. As I progressed through that, it became increasingly obvious that there was some pretty big gaps in our services and definitely in our preparation strategies for people who are experiencing homelessness, people who use drugs. And I quickly went down the rabbit hole of getting myself involved, and very quickly was working as a nurse at the homeless encampments, helping people get started on safe supply, working on various committees like the Victoria Inner City COVID Crisis Response Group, which is a group of physicians who have been fantastic for implementing safe supply, or PPRM, and a whole bunch of other stuff that I won't bore you all with today. But I am very grateful to be here and appreciate the opportunity to speak on this very important subject today.
Awesome. Thank you, Corey. And maybe we'll just continue with Tim. So if you don't mind introducing yourself and what's been your role and what are you doing currently to support people use substances during COVID?
Yes, well, hi everybody. My name is Tim Goche, and I'm a full-time nurse practitioner. I split my time to a couple of different sites. So I work primarily at a withdrawal management program called Creekside, which is located in Surrey, BC. And then I also work 1 day a week in the downtown east side in an urban primary care setting where I do safe supply prescribing. And I'm also the vice president for the Harm Reduction Nurses Association. So I think I'll leave it at that for now.
Perfect. And I'm sure people will have a lot of questions, especially with respect to the NP role and what the role can do to help implement these guidelines. Maybe we'll go on to Megan. Megan, I don't know if I think you're still muted, so maybe just check yeah, okay, perfect.
I'm muted?
Yeah,
Great.
you're okay now.
Okay, great. So my name is Megan Chumath. I have a few different hats, and happy Nurses Week, everyone. I'm a clinician scientist with the Center for Gender and Sexual Health, and also a clinical faculty with UBC School of Nursing. And then with respect to the guidelines, I've been working as kind of a consultant clinical advisor for Vancouver Coastal Health for the COVID-19 response for vulnerable populations. And then very part-time, I work for the World Health Organization as an infection control expert on the COVID-19 response, mostly for the Africa region, and formerly headquarters on Ebola. And my work in this area has primarily been around helping one of the many co-authors of the guidelines, a huge part of a big team, and then also working with VCH on all sorts of different aspects of the response. From, I think we talk about our pillared approach, so prevention, testing, and tracing, and support, and just kind of working across those as a tiny part of a really big team. And look forward to chatting more about that with questions.
Perfect, thank you. And Guy will conclude this panel introduction with you. And just make sure you unmute yourself.
You guys can hear me?
Yes, we can hear you very well.
Okay, Guy Felicella. I am the peer clinical advisor for the Overdose Emergency Response Center and also the BC Center of Substance Use and Vancouver Coastal Health Regional Addiction Program. My job is obviously long, but I work with people with living experience, recovery initiatives, harm reduction services, and also a co-author on the risk mitigation guidelines as well. And looking forward to hearing everybody's questions. And happy Nurses Week.
Thanks. We should have opened with that, but typical nurses just focused on getting the job done. Thank you so much for that great introduction. And I have already one question lined up that I think is interesting. So I have it lined up, but I just want to encourage everybody at this point, because we're hoping that you'll throw some questions at us. So make this an interesting panel if you want to type in your questions so we can start selecting them and lining them up for our panel. The first question, and I thought that was an interesting one, is someone was asking about are medications being mailed or delivered in some way to people who can't leave their homes, go to the pharmacy, or maybe for other reasons, for example, being immunocompromised, for reasons of wanting to isolate, staying home. So what's been your experience of getting medications to people?
I can start off with that if that's okay. This is Corey Ranger here. My context of work has been in the homeless encampments in Victoria. And one of the things that's really critical about the PPRM and the safe supply is that we really do our best to actually meet people where they're at and to try to make sure that they have timely access to their medications, and that in the face of this dual healthcare crisis that we can support them to shelter in place if they need to, even if that is in a tent. So early on, one of the strategies that we implemented in the encampments through the work with Vicar was to have the nurse pick up the medications and deliver them to people's tents, particularly if they were people who were symptomatic and needed to isolate. As we gathered more people who were on Safe Supply, we were able to work with a pharmacy who would actually take over those prescriptions and bring a nurse to the sites every single day to deliver the medications. This is a really critical piece because you could lose someone and they could slip through the cracks if you're not finding an option for someone to get their medications as quickly as possible. So we were very fortunate with that, but I am interested to hear what other experiences have been across the province as well.
Awesome, that's a good example. I don't know if other people wanted to jump in with their specific example, and of course I have a few questions lined up, so if there's any silence, I'll just jump in.
It's Megan here. I don't know if you can hear me all right.
Yeah. Yes.
Yeah, I think for in the Vancouver Coastal Health region, certainly pharmacy delivery has been really important, but one thing I thought I would highlight, and we've talked about this before, was just the importance of sort of patient choice. And so initially folks thought that people would want like larger carries, say a week or even a month. And it was actually drug users themselves, some of who said, no, for some of us, we might want daily. For instance, women talked about gender-based violence and how if they had a large drug supply and it was known in their SRO or in their single room occupancy hotel, that might actually place them more at risk. And so for them, they might want the option to be able to say, this week I want daily delivery, and then in other weeks I might want, if I'm a longer supply. So I just thought that was interesting.
Yeah, and there's maybe I'm going to combine two questions here, but there's some questions coming up in terms of some concerns around framing this around pandemic prescribing, and also what's going to happen post-COVID, and what kind of discussions are already happening to make sure that this is not just like a moment in time, but this is a standard of care that will be continued. So maybe, I don't know who wants to jump in and maybe start this conversation, but I just melted two questions there with that one.
I think it's the question that everybody wants the answer to, and I would love to hear Guy talk about this as well, but I had the opportunity to co-present last week with Dr. Jane Buxton, Dr. Danielle Van Smith, and Justine Patterson from the Overdose Emergency Response Center, and I asked them specifically this question about what would be the likelihood that we can get some longevity out of Safe Supply, and that it wasn't something that was just contingent on a pandemic. And really the intent and the desire is that this is something that proceeds past COVID-19. There was an opportunity with the need for people to shelter in place that it made even more sense to implement Safe Supply for sure. But we've been calling for Safe Supply and advocates and people with lived and living experience have been calling for Safe Supply a lot longer than COVID's been a thing. And the goal in my mind is to establish these systems and put everything in place so that it's just really difficult to take away afterwards, because what we really need is buy-in and champions so that we can get some sustainability out of this model.
Yeah, I agree. I think if you look back, it's just really history repeating itself from, you know, the reason why the supervised consumption site was implemented in 2003. Really, we were dealing with two public health emergencies again, which was HIV and the overdose crisis in '97. But it was more on the lines portrayed through the media and through governments that, you know, it was an HIV problem and the infections were increasing. And so as now we've been in this overdose crisis since 2014 or 2016, but actually even a few years earlier. It wasn't declared until 2016. But the unfortunate thing is really the pandemic was the catalyst behind these guidelines being implemented. And so it's a COVID response However, when COVID's finished, the overdose crisis is still going to be there. And now, especially with the borders being closed and the drug supply being disrupted, and if you look at, OAT in itself, it's just not enough to compete against fentanyl. And so the real option is in a combination with OAT and hydromorphone or MS-Lon. It gives people a little bit more stability in their lives. And I mean, I'm telling you, it is a mental grind to be entrenched and dependent on a substance. And then as soon as you've done it, your immediate thought is the next one, because you know what's looming. It's that withdrawal. And it's so powerful and takes such a mental toll and a physical toll on your body that, I mean, it's just literally exhausting. And so now we have an opportunity with these guidelines to actually, really help people, break free from that, not only the dependency piece, but also give them an avenue to do something else and become and take away that what it takes to go get those drugs. And it's been challenging.
And just to follow through on like one thing you said there, how this is like an opportunity, like this really is a golden opportunity for prescribers to get to get into this. Because one of the big limitations for nurse practitioners and anybody really prescribing this way is that we are to prescribe, in line with the evidence. And the unfortunate thing is that we don't have a lot of robust evidence around, prescribing replacement stimulants for the purpose of achieving abstinence from other stimulants. But with this pandemic prescribing, that's not the explicit goal. The explicit goal is that we're allowing people the opportunity to not engage with an illicit and poison drug market, but also so they can isolate, which can help us whittle down our reasoning and our defense in the way that we prescribe this medication or these medications. And I hope that made sense.
Thanks. Wow, this is a great panel. Like I have to read the questions. Like I was just listening to you guys, but I would also merge two questions together. And for the audience, just know that I'm reading all the questions. I'm also trying to give a chance for everyone to get their questions. And if I can merge them, I will do that so that we can get as many in. But there are two questions related to non-urban settings. So how do you envision these guidelines being implemented outside big cities, including in provinces where even the discussion around safe supply might not really be happening to the level that it is in BC? So I think that's an interesting one. And I'm sure a lot of people that are joining us tonight are not working in big cities with a ton of resources. So what are your thoughts on that?
I can maybe make a quick start at this one, because I'm sure that Guy and Corey probably have more to say about this than I do, because they're more on the ground fiddling to make all this happen. And I work in an urban setting, but I have been reaching out to my colleagues who work rural and who are trying to prescribe the risk mitigation under the risk mitigation guidelines. And they've been saying they've had to work really creatively with pharmacies, because sometimes the pharmacy might only be open for a few hours, like 3 days a week, which makes it really hard for someone to go in every day to have like a daily dispenser witness ingestion of a medication. So some of their strategies have been to just work collaboratively with the clients to like determine like long-acting therapies. So instead of getting like maybe like short-acting dexedrine and a series of tablets, reducing the amount of those tablets to long-acting capsules so the amount is smaller, ensuring that there's a lockbox in place or a safe way to keep it, and then kind of have that self-monitoring in place with a smaller amount of medications. And then to check in, like midway through the week and see how that's going, and regular check-ins remotely, but then try to readjust the plan in a collaborative way.
Yeah, that's great, Tim. And I think one of the things to acknowledge too is even when I read the risk mitigation guidelines, I know that there's a very small kind of shout out to rural and remote areas. And that's because those areas have always been met with significant challenges when it comes to resource scarcity, when it comes to ability to access medications in a timely manner. And that's really part of the role of the nurse as well, in that nurse's advocate role. It's not necessarily just, advocating in the activist sense, but actually reaching out to prescribers, reaching out to pharmacies, and doing the education so that you can find out if delivery is actually a possibility, and finding out where the gaps in knowledge are so that you can support people in a better way. I know previously, I believe Megan had mentioned about the 23-day carries and how that didn't always match up with people's lifestyle, and it often created safety issues for folks. And that's certainly the issue as well that we experienced in homeless encampments in Victoria, that to give someone who's sleeping in a tent 23 days worth of carries would likely create a little bit of a safety issue for that individual. But that may not be the same case for people who are in rural and remote areas. So it's important to really look at those guidelines and know that there is a possibility for people to get longer carries, and that's on us as the nurse to advocate for that if that's what would best meet the needs of the individual in that circumstance.
Yeah, no, great points, guys. And I also think too, where I've always seen something to be really valuable in smaller communities, which is the at My Safe vending machine. If there's challenges with pharmacies, that could be a great option for communities to have a machine that's like the one at right next to the Vancouver Ops in the downtown east side in those communities, because then the pharmacies would load the machines and then people would go to the machine instead of if it was challenging or pharmacy hours were closed. So I think that machine can be there 24 hours a day. It'd be in a secure area, and it's basically a safe. There's just absolutely weighs a ton. So could be an option to look at.
Yeah, and I'm curious, jumping in with another question here that I'm sure it's on a lot of people's minds, is what if people don't have a primary care provider, or what if their primary care provider is not willing to prescribe? So what have you been encountering, ways around that? Like, how do you work with that situation? So I'm sure you've already seen this in practice and have a lot to say about this.
My goodness, yeah. Yes, you can go first, Guy.
Yeah, it's unfortunately, you'd hope doctors would look at their medical practice with a harm reduction approach and a balance, and unfortunately, some people I've known people that have gone to their prescriber and asked, and their prescriber for OAT said no, absolutely not, and then them go and get another doctor that actually did give them safe supply, and then had their OAT carries actually taken away, where they had to go in and get them picked up every day. So I've dealt with many calls across the province, and it's been challenging for some people. And unfortunately, the culture that exists in language such as drug seeking and doctor shopping is really impacted substance users' lives. It kind of reminds me of trying to access methadone in the 90s. It was extremely stigmatizing. And then if I was using drugs, I'd be like, they would say questions like, well, look, you really need to get help for this. And I was like, look, I'm not here for help for my mental health and my addictions. I'm here for help with this, my opioid use. And you're a doctor that says you can help me. But, so I think there's a lot of, deep rooted culture in this. And I think just you run into people that are not comfortable with it. And I just describe it as if your client or your patient is on OAT, and that person leaving is going to actively continue to use fentanyl, then how would that not be something that you would look at? And I've always said this, that if medical professionals believe that opioid use disorder is a chronic relapsing condition, then why would they resist prescribing safe supply when it's pretty much the antidote or vaccination to help people from overdosing? So, you know, I'd hope that you know, through these webinars that we could get more people on board, but I also believe that nurses and nurse practitioners play a vital role in this, because you guys really know the people that you're working with as well, and I'm sure people open up to you. So I think, you know, to be that advocate as well, you know, to change a culture, it's uncomfortable, and uncomfortable conversations have to happen. And I think, you know, as nurses, I know you guys play such a huge role in substance users' lives, and are, you know, very compassionate in your approach. And I think that's what I'm hoping for from this webinar, that will come out of it, so that substance users can, you know, start having some freedom.
Yeah, I'll just echo exactly what Guy said, and maybe try to provide some more context to it. Thank you so much for that. Given that you started with that comment about people who use drugs, I would want to say to everyone that the best form of advocacy, and this is directly pertaining to this question, but the best form of advocacy I can propose to every one of you is that if you're at a meeting about safe supply or about service delivery, and you look around and there isn't someone with lived or living experience at that committee, the first thing you need to do is say, where is our voice of living experience, and why aren't we consulting with people who are actually impacted by our policies? Because it's still a recurrent fatal flaw in the things that we develop. And this COVID crisis has been really emblematic of the fact that we'll just throw everything at the wall and hope that it sticks before consulting with people with lived and living experience. There certainly are a lot of connotations of OAT paternalism still in the safe supply process. And when it comes to getting people on board, a lot of people that I speak to, a lot of nurses want a specific roadmap for how they can get people onto safe supply, and what happens if somebody, what happens if a prescriber isn't willing, what happens if there is no prescriber at all. And really, you need to treat it by a case-by-case basis. When we first started out with safe supply, I was working in the parks, and it was just a matter of calling physicians. And I was doing the doctor shopping for the patients and for the clients to find out who would be willing to prescribe. And one thing that I should say too is that to expect your patient or to expect your client to self-advocate can be really problematic, because they've already faced likely a lot of trauma at the face of the healthcare system. And then to have them have to call their doctor and say, hey, can I also get some Dilaudid? Can I get some Ritalin? That can just set them up for more trauma. So when you're working with someone, the first step first is, do you have a primary provider? And if you do, let's call them together and let's explain the risk mitigation guidelines. Let's explain why you need to shelter in place and why this is the ethical and evidence-based thing to do. We had a situation, and this is just reflective of some of the early flaws or early kind of barriers in safe supply, where there was a young person who was at incredible risk. Their substance use was dependent on someone who was taking advantage of them on a regular basis and victimizing them. And their primary provider was a recovery doctor who, when I first called, laughed at me and said, I'm a recovery doctor, not a Dilaudid doctor. And that was really problematic. That was really hurtful. We didn't really know how to proceed after that. And it took multiple phone calls with different doctors until we were able to fire said doctor, get the patient a new physician, and then get them onto safe supply. And that one person took up probably an entire day's worth of work. But the more champions we can develop, the more physicians we can get on board, the more normalized this process gets, and the easier it gets to get more people on it for a sustainable amount of time.
Yeah, and maybe I can jump in, because someone mentioned, I think it was you, Guy, around like a shift in culture that has to take place. And maybe just to piggyback on what was just said around pharmacies, what have been some of your good experiences working with pharmacies. Maybe there's some concerns here about maybe some pharmacies being resistant to this type of practice, or like what have been some of your success stories or innovative ways, creative ways of working with pharmacies?
I have a very brief thing to say about this, is that some of the prescriptions that I sent out that have been daily dispense, like some pharmacies have tried to give pushback, saying that that's kind of like contrary to what we're trying to do with this risk mitigation prescribing, so people can isolate and not be in public and not be accessing pharmacy every day. But then that goes against the client's goal sometimes, or their stability, or the plan that we've made together. So it's massaging that with pharmacy, because especially as the COVID stuff was first starting to amp up and everybody was worried. Pharmacists are worried too about the amount of foot traffic. So it's really just about coming back to our obligation to provide that continuity of care despite this crisis, because we are managing, two at once.
And even one of the things that I always tell individuals when, because some pharmacies were, when people were getting the hydromorph, if they had so there's for the dilaudid, there's two dilaudid, well, there's three dilaudid. The generic, which is the Purdue, which is the round one, which no substance user likes. And then there's the generic APO, and then the name brand hydromorphone. The APO and the name brand are, if you go into, so I always say to people that get the scripts, go into the pharmacy and ask them exactly what brand that they have. And if they don't have the APO or the name brand, and they only have the Purdue brand, which is the circle one, then just go to another pharmacy, because there's no point in getting something that's generic that you're not going to take anyway. So so really what it is just, I give the patient the information to bring to the pharmacy, so that there's no misups. And I know some guys, they even get Metadol D scripts that go to their pharmacy, and all of a sudden they get methadose because the pharmacy doesn't have it in stock, or whatever the reason is. I just say you got to ask those questions before you hand over the scripts. It's one of the things. But the good thing also is now that the scripts can actually get transferred to other pharmacies. However, in doing that, when you have one, then it's, you got to go to another pharmacy, and then they got to fax the stuff over, and that takes just too much time. And a lot of the times, that's the challenging piece for anybody that uses drugs. They just want to get in and out, and some would rather not even deal with a pharmacy if they had to.
Perfect. Was there anybody else that wanted to jump in on this one? And just maybe a point of clarification, I think some people are using the question box as a chat box, and so it's creating quite a challenge for me, because I have to then realize that you're just commenting and you're not really asking a question. So if you want to chat to the entire group, you can do so using the chat box, but the question box, please make sure that it's directed a question at the panel. It's very helpful for me, and then I can translate that into a nice question to our panel. So I think there's some questions. I'm gonna again merge two that I saw around how do we implement this while in the midst of COVID, there's been a reduction of services, or even in some areas in Canada, some services are not even available. Like we're talking harm reduction services or supervised consumption services, or, basically the kind of services that we wish all people use drugs would have access to in Canada. So there's, and even in cities where that's available, it's been reduced, or services have had to adapt or go mobile. So how do you ramp up these guidelines and access to safe supply while also dealing with a big change in services? So what have you been seeing on the ground, and how are you adapting to this?
It's Megan here, if I can jump in on that. I think that's where these guidelines offer such a great opportunity, because many aspects besides the urine drug screen can be really conducted over the phone. And so certainly we've used a lot, and a lot of our prescriber colleagues, whether they're NPs or physicians, are able to do most of this work remotely. And so it's I think what's so useful, and Health Canada's also made some changes to some of the national regulations that have really helped us out. So I think as a nurse advocate, it's really important to stay on top what those changes are, and our colleagues don't always know them. And so BCCSU has been really helpful in sort of, they've created a landing page on COVID-19 that you can go to kind of stay abreast of what changes have been made to the Controlled Drugs and Substances Act and specific exemptions. And maybe Sam wants to talk specifically about those, but they're on the website. And I think it's just helping everybody and being compassionate and patient with our colleagues who are also struggling to understand this new world, and just backing up what we say as nurse advocates with, emails. I'm famous for my here's the link to this change in guidance, number 1, number 2, here's the prescriber guidance, and just taking really advantage of the new changes that we have, which are also helpful for our rural and remote colleagues around being able to do this remotely.
There was also a mention, I don't know if Corey, you want to jump in on that point around non-urban areas of also everything that comes with living maybe in a smaller area where people might know you, and navigating kind of the complexity of living in smaller areas where, with trying to access services or going to the pharmacy, that might be a way of disclosing that you're using substances.
Yeah, I mean, that's a tried and true challenge of rural and remote care, and even earlier on in my career working in HIV care in rural settings, being able to maintain anonymity, being able to get people access to care while also protecting their confidentiality and their dignity within the community, or whatever that might be perceived as, is really paramount. And I remember I received a phone call about 2 weeks ago from a care provider in a rural area on the island. And they were asking me how to get this individual onto Safe Supply. And I went through the process with them, do they have a prescriber? Okay, they have a prescriber. You need to call the prescriber first and find out if they're willing to prescribe, explain to them the guidelines, let them know that this is something that's okay, talk to them about pharmacy delivery. And then they said, well, what happens that this particular prescriber is not willing to prescribe? And I said, well, you should call the advocacy line on the BC Yukon Association of Drug War Survivors, and they'll support you. And he said, oh, I called them and they told me to talk to you. And I was like, oh, crap. But it's really important because what we did in Victoria was we established, and it wasn't me, it was this group of physicians who established this network of doctors in the inner city and this Victoria Inner City COVID crisis response team. And by establishing this group of champions who became really well versed in it, and they had conversations with their colleagues, what they are now is resources to other prescribers as well. And so when we run into situations where rural and remote prescribers or pharmacists aren't willing, we have to lean on the prescribers and providers who have been doing it and see if we can kind of create those internal champions. A physician-to-physician conversation about Safe Supply alleviates much more anxiety than any other kind of form of communication. And so that's also part of the job of the nurse here, is to really try and liaise those connections and develop those networks so that people have some kind of support that they can lean on, even if you're a prescriber. This is new to a lot of people, and so it creates a lot of anxiety. And if you're a rural or remote provider, it's even newer to you. And so there's lots of concerns about liability and what does this mean for my college. And if you can connect someone to a provider who's doing this already, who's respected in their career, then you can really help facilitate that growth in practice for that individual.
Yeah, and on the topic of breaking barriers to access, maybe Tim, if I can just call on you to kind of jump in regarding the role of the NP, especially in an outreach capacity. Where do you see this role, and kind of what can NPs do?
Yeah, so NPs have immense potential to really take this up and to really move this forward. Part of it is because we don't participate under fee for service model, so our day is kind of set that we'll have 8 hours of our shift, and we can kind of structure it how we need to, depending on the employment structure. But it's feasible for an NP to be doing outreach as long as their employer allows them to do it. A lot of my colleagues, yeah, a lot of my colleagues who I reached out to in preparation for this seminar actually hadn't heard about these guidelines at all. They were kind of aware that there was something about risk mitigation prescribing, but didn't really, look into it too far, because right now we're inundated with updates all the time around COVID. So some of these things are slipping under the radar. So my colleagues who had good experiences or favorable experiences, often it was because an outreach worker or somebody had called them to talk to them about one of their patients who was looking to get established on risk mitigation prescribing. And they walked them through what it is, and they walked them through what the guidelines are, which kind of goes back to what Megan was saying about attaching the information to your communications, if it's email or whatever it is. So if NPs can get prepared with the knowledge, that's like the first step in this. The second part is that NPs do have a little bit of certification they will have to do to get into, like, to be able to prescribe it, like OAT, which extends to this risk mitigation prescribing. So there's a small hurdle that NPs could do, and I would say NPs should do, because I don't think that we should be getting an allowance to not be treating somebody's substance use, especially in the face of a public health emergency, which is the opiate overdose crisis, which is what I'm talking about there. Yeah, so I think the time that we have available to us, the way that NPs practice, where we are meant to be treating the whole person all the time, so looking at the human in front of us, their environment and their health, and then, how does nursing fit into that? We have a lot of potential.
Thanks. There was a question around assessing or measuring wellness, like how, once we're talking about putting people on, like, say, supply, barriers to access, all these things, but let's say this is all working well and someone has access. What then? Like, how do you work with a person to know, what's working, adjusting, all these things, and how do you measure kind of wellness? And that's coming from Karen. So thank you for that great question. And I'm sure, Guy, you have a lot to say also about this. So whoever wants to jump in first, go ahead.
Yeah, I can elaborate on that. I think when you look at somebody's health and well-being that gets on it, and I've had many people contact me, literally breaking down on the phone in tears, just because of the relentless grind that a person with opioid use disorder or substance use disorder has to go through a day. And I know many survival sex trade workers that they no longer have to do what they need to do to get their drugs, and that is, when you look at wellness, if somebody's mental health improves, their anxiety improves, and their overall health improves. And if you look at the concept of how people believe, usually people in addiction treatment, they always say, well, you got to get off the drugs first in order to change your behavior. And I think it's actually the opposite. What if we gave the drugs so that the behavior to get the drugs, that habitual habit that you just get up and do, if you gave people drugs, they could actually address that by not doing those destructive behaviors that are really the shame and the guilt that keep you entrenched in it. Then maybe people could actually free up a huge department of their life where they could actually focus on doing other things. So I don't even focus on the drugs. I just focus on how I can improve the quality of their lives. And if it's through a medication, it's really, like diabetes. If somebody goes off their medication or is on medication and goes and eats a bunch of junk food, they don't cut them off their medication. And if somebody's on medications that you're giving them for substance use and they're using other street drugs, then you don't cut them off of that either. You try to improve that. And I think that's where we have to get to, in trying to not focus so much on the drug as a safe supply, but as a this is a life-saving medication that could change the trajectory of somebody's life. And I get even overwhelmed when I think about it, and people call me, and they don't have to get up and go crazy. And I mean, it's punishing. And take it from me, I did it for 30 years, and I'll never forget. And you know, every day I walk, my body and my back reminds me the punishing impacts that substance use and being homeless does on a person's body for years. So if we can reduce that punishment on somebody, you know, sky's the limit for their lives.
It's Megan here, Guy. That's super powerful, and thank you for sharing that. I think Guy's really highlighted the importance of capturing this qualitative data and the stories of our patients as advocates. And then I would just maybe add with my nerdy clinician scientist hat, if I understood Karen's measurement question too, if you are involved in research or evaluation and you're doing this in any of your sites, or you're like a nurse policy person, I think it's important to not have the urine drug screen, you know, a urine drug screen obviously doesn't give us any information if you're evaluating this. And so for me, it's like employment, connection with family, it's decreased hospitalizations, decreased interactions with the criminal justice system. And all of those we can look at with administrative data for the most part. So you can really help, I think, build the case for this program to continue. And it's going to be really important for those of you who are prescribing or involved in supporting a group that you're keeping a caseload, that you're keeping a client list, just like you might do with a primary care registry, so that we can evaluate this. It was implemented so quickly. Being part of the folks who implemented it, we talked about evaluation. We didn't want it to be a barrier, and we launched this so quickly. But it's going to be hard because it is quite a grassroots initiative to capture all the data afterwards. I don't know if Sam or others have more comments. I know there's plans provincially, but I think that anything you can do at your clinic level to be capturing who is using these guidelines and how much hopefully their lives are improving, that will really help us make the case to continue it.
Yeah, it's Corey here, and I'm certainly not a researcher or a scientist by any stretch of the imagination, but part of my early strategies with people on Safe Supply in Victoria was to try and pull any kind of aggregate data as we went along, and to be able to report that back to the physician. We had a young couple who was one of the first people we got started on Safe Supply, and their pre-Safe Supply, pre-PPRM prescriptions, their life was quite chaotic. They were constantly, you know, in turmoil, and they were fighting with each other and just trying to see what they could do in order to get access to their medications next. And after we got them on Safe Supply, the change was so brilliant and clear. They were supporting each other. They were helping out around the camp, and to be able to give those quick snapshots of some of the benefits outside of what a UDS can show, which is really a stale metric, but to be able to show those benefits and provide that as a form of positive reinforcement for prescribers to say, like, look, this is what this is doing right here, right now for these individuals, is a really positive thing to show. We also need to make sure that we're supporting physicians and other prescribers in wherever they're at in terms of their comfort level. So there's some prescribers who have been willing to put people on, and they only want to do check-ins at certain times. And there's some prescribers who wanted me to do daily check-ins where I called the prescriber and we had a phone call between myself, the prescriber, and the client every single day to see where they're at, and making tiny little adjustments. And that helped that prescriber, as that was the first Safe Supply prescription for that individual, really get familiarized with the process and to get more comfortable with it. So again, as nurses, make it as easy as possible for prescribers to be able to do this and find as many innovative solutions so that you can make this process streamlined, and you'll see more buy-in from it for sure.
And Corey, while you're on the, oh, sorry, Tim, did you want to go in?
Yeah, it was just, but I can wait. I was just going to talk about clinically how I document or how I kind of frame those like assessments in my documentation.
Oh, go ahead, because I just want to just catch Corey on something because someone had a specific question, so I'll go in after.
Sure, and this is like really short. It's basically just like how I frame everything that Corey, Megan, and Guy has just said. Is that I usually just write like client reports these improvements, and then I do like a colon, and then I just hit it with bullet points like decreased use of crystal meth, able to self-isolate, decreased withdrawal symptoms, improved quality of life, mood improved. Like I kind of hit all those things that people are telling us about what's going on with them since they've been able to access a safe and regular supply of these medications. I just make it really clear, really bullet pointy, so that later when we are at the point of data extraction or reviews, it's really easy to find.
That's a great approach, and thanks for sharing all these tips, because I think they're really helpful for people who are kind of thinking about their own practice and how they can be doing this. Yeah, Corey, while you were there, I was just reading the question, and someone had initially asked about who's doing the initial assessment and prescribing at the encampment, like in your experience of working with homeless people in an encampment setting.
Well, the process started with me phoning physicians and saying, hey, I have this person here and they just overdosed, and I'm wondering, now that these safe supply guidelines are out, if we can talk about getting them access to safe supply. And I helped create an intake and assessment form that was just like drug use history, preferences, history of overdose, obviously throw in a COVID screener in there, because it's always good to check if people have a new onset of cough, shortness of breath, or fever. And then I would I would provide that assessment over the phone. The physicians group who I worked with has grown exponentially and has really risen to the challenge. And so now we have on-call physicians in Victoria who come to each of the encampments and will be coming to the hotels when we transition over to hotels, and they're doing in-person consultations, which has been really great and really streamlined some of the process and taken away the gatekeeping that can happen sometimes, because we saw a lot of peers and a lot of other workers who were like, it's great that you're able to talk to the doctor and get this prescription, but you're not here all the time. And finding ways to get the doctors on site and to support them so that they can do that important work is just really critical to do. But early on, it was just problem solving and figuring it out on a person by person basis.
Thanks for that. I just want to jump into alcohol, because I think the goal is not to leave the impression that this is just around opiates. So what has been your experience around people accessing a safer supply of alcohol? And how do you see this being integrated into your practice, or what are some of the barriers you're seeing or successes? I think it would be good to have a little bit of that on the panel tonight.
Yeah, alcohol is the forgotten variable quite often, and that actually ended up being one of the most urgent issues that we encountered in the encampments, was that people had a disruption to their access in alcohol. And very early on, before there were any supports in place, there were people having seizures from alcohol withdrawal, not able to access withdrawal management services if they wanted it because of disruptions in services. Or restrictions in bed capacity. And so we have seen two different versions of managed alcohol emerge in Victoria. One that is quite a bit more on the medicalized end of things, and people can go into a hotel if they're a good candidate. They have to screen through specific criteria, has to be a high equivalence of drinks and at risk of withdrawal or already in active withdrawal, or at risk of using non-beveraged alcohol, and then they could qualify and get into that. That one has had hit or miss successes, opportunities, and challenges for sure. The barriers are definitely visible, and it's impacted people's ability to stay in that kind of program. And then all the way to the flip side of that, there's been a very low barrier managed alcohol program initiated by peer organizations in Victoria. They're calling it AMP, which is Alcohol Management Program. And they're just doing, what do you need? What are you drinking? Do you have the ability to purchase it right now on your own? No? Okay, we're going to deliver this amount to you at intervals throughout the day. That too has been successful in the fact that it's met people's needs, but it's definitely not the perfect model. What we found is that just dropping off a certain amount of alcohol, like a large bulk of alcohol, doesn't really do people the service of staving off withdrawal. And what we had was there was a lot of folks who were highly intoxicated early in the day. And so there's some kind of middle ground that we've yet to achieve. One of the big problems is that managed alcohol in a lot of settings has been delivered successfully through that drinker's lounge style, where people can go, they can get what they need for that moment, and they can come back if they need more afterwards. That doesn't exist in the time of COVID because public health interventions and public health recommendations don't really speak to the local context of people who use substances and people who experience homelessness. And so we're still definitely trying to troubleshoot and find out what the best possible strategy is for meeting people's alcohol needs.
That's an awesome answer. Anybody want to add to this?
Is Megan just maybe to make a plug that just to demystify managed alcohol a little bit? I think the drinkers lounge example that Corey talked about is the sort of thing many people have in their heads, and that it's actually can be a lot simpler than that, and it can be as simple as like helping a client advocate to have a bottle of vodka kept, at their supported housing site if that exists, and that's doled out in certain amounts, or it can be as simple as working with community organizations to develop like a beer, brew your own kind of style, and with existing community organizations. And I think Bernie Polly and colleagues of yours, Mary Lou at UVic, have done a great job of summarizing the different models. And so if folks don't already have that at their fingertips, then I think it's the Canadian Managed Alcohol Program study, and it's got a website with overviews of all the different programs and where they are and how you can build your own. So just a little plug that sometimes it's simpler than it seems.
Yeah, I like that. And I think it's good to hear examples too, because it's a good reminder of different ways, of creative ways that people come up with to implement a safe supply. And there was a question around what if the provider is not into prescribing and refuses? Like how do you go about that? Because that person is needing that provider for their care. How do you navigate that kind of situation? Any advice? I'm sure you've probably been in a situation similar to that.
Been in a few situations like that, and I obviously described the one situation where we had to get an altogether new prescriber for that individual, but it doesn't necessarily always have to go that way. And I think to that person's question, to the intent of that question, is that you don't want to kill really good relationships that people have with their prescribers just because there's some reluctancy or some hesitancy or maybe even some fear around safe supply. And so there's other opportunities to foster good relationships. There's lots of really great physician to physician webinars and educational opportunities that the BC CSU has put forward to help do that peer-to-peer, doctor-to-doctor education, and just making sure that you have all of the evidence and the education behind you so that you can advocate for an individual and let someone know why this risk mitigation guideline exists, what the benefits of it are, and then offering supports and resources for people to gain access to them is really great. I know early on our physicians group, there was some, we had open door and everybody was getting on safe supply really quickly, and then there was a quick pullback because people became a little bit concerned or fearful about what follow-up looked like. And we were really beneficial. It was really beneficial that the physician group was able to talk to physicians in Vancouver who had been doing this for a while and could lean on that resource to figure out what would be the best strategy for them. So trying to facilitate those opportunities can be really beneficial for prescribers.
I was just waiting to see if anybody else was going to jump in. And the question that came up early, I'm just going to pick up on that one now. What about diversion? Like, and I don't know, Tim, if you want to, and Guy, if you want to kind of start the conversation maybe around, like, is there a conversation about that? Is this coming up when we talk about safe supply? How should one approach this?
Yeah, I mean, I don't know. I I mean, diversions happen for decades. You know, obviously, I think too, when you're, you know, you want to be really, you know, I think one of the ways that I've gotten around, you know, getting people prescribed is the fact that, you know, with diversion, of course, you know, it happens, but where it's kind of happening a lot of the times is people are, you know, instead of diverting fentanyl to unsuspecting people, you know, a couple times when, you know, it's not uncommon for people that use drugs to help each other. You know, it's really, you have to look at the community helping each other. And that's the way to, you know, to show support to people that are struggling. And so, sure, I mean, if I had, you know, a prescription of Dilaudid and I saw somebody that wasn't feeling well, yeah, I mean, I'd give them a couple. You know, and you're also looking at, you're not diverting contaminated street drugs, at least people that are going to, you know, it's very rare for somebody to die from a prescription of hydromorphone. So obviously I think it would be very rare for somebody to die from doing Dilaudid on the street as well. What they will die of is fentanyl. And I think, you know, when you're, if you, you know, when you know your patients and the people that you're dealing with, you know, it's one of those things where, you know, it's so complex with, you know, a lot of it has to do with poverty and homelessness and just that oppression. And it's not really the diversion that's so dramatically looked at. I know it's heavily talked about and it's hard to get around. But I think, you know, you also have to put your patient at the best possible way to not divert, and that might be for a particular person that they might have to get it, you know, twice a day instead of getting, you know, all 14 at once. Maybe they get half of that and come back and get the other half later. I mean, it just depends on the individual. You know, I don't think there's, you know, I know some people are very good at managing, and then also too, you don't put people at risk. Obviously, the street police is itself, so you just want to protect people as well. And so the best interest, and I've always said that, you know, if we make it more challenging to come to us to get help, if it's easier to go buy drugs off the street, then that's what people will do. People won't go through these rigid barriers and regulations in order to access services. They just won't do it because drug dealers don't do that either. So until we get to a place where, you know, and I think one of the biggest things that I've ever heard about diversion is that it's not going to youth regardless. If youth want substances, they're not coming to buy Dilaudid. They buy other stuff. So that's one of the things that I try to, they're not being diverted to youth or you know, people that aren't using them. So usually amongst the community in itself, you know, it's always existed. And I know for years at Insight, you know, you couldn't pass drugs there, but you know, it happens. And so will it kill somebody to do Dilaudid? Probably not. Will it kill somebody to do fentanyl? Definitely. So that's where you probably have to start looking.
Thank you. And I think that you just kind of hit the essence of harm reduction, right? It's just like you have to approach this not based on your own kind of worries and fears, but really kind of connect with the person where they're at and also where the community is at, right? And so I thought that was a wonderful answer and super helpful for clinicians to hear from your experience as well and your point of view. Tim, I don't know if you had anything to add, or do I just kind of start wrapping up? No? Okay. Well, I'm just looking at the time, and I think it would be really nice if I gave each of you a chance to kind of sum up your thoughts and maybe any final thoughts or tips, advice words of wisdom to share with our audience. So let's just start maybe with Corey. I'll go back to the top. Any final thoughts?
I think poor Tim is experiencing some audio issues, so I'll apologize on his behalf. But my only last point is just to echo what Guy has said. Sure, there are potentials that drug diversion can occur, but when it comes to harm reduction, when it comes to the illicit fentanyl poisoning crisis, the lesser of the evils, or maybe non-existent of the evils, is the safe supply. We had a day in the encampments where we had 7 overdoses in the day that I responded to, and 5 of them in 1 hour. And I spoke to a physician shortly after that and tried to get someone onto safe supply, and they said, well, we can't just flood the park with Dilaudid, Corey. People are going to overdose on Dilaudid too. And I actually had to say, there is a mass casualty incident going on where people are dropping like flies right now. Do you actually think introducing Dilaudid into this encampment is going to make things worse, or do you think it's going to make things better? And it was just a timely statement because that physician decided to prescribe on the spot for that individual. So continue to advocate, continue to educate people who have the power to prescribe, people who don't understand this, and happy Nurses Week. Thank you to everyone who attended today.
Thank you. Let's go to your final thoughts, Guy.
Yeah, just, I mean, I think one way to, ask a doc, if you have a doctor already prescribing Cadian, and they're not interested in prescribing hydromorphone or Ameslan, you could basically use that as the catalyst to say, look, you're already doing it. You're already prescribing a safe supply by prescribing Cadian, which is a morphine. Just the individual that you're advocating for prefers this one. So you can kind of get the shift, and that's actually worked a couple times for me as well. So it's really not out of the realm of just that extension of OAT. I try to get them to focus on that. And if they don't feel comfortable in prescribing stimulants and benzos, then I just say, well, then don't. Just prescribe the opioids that this is what the person's seeking, instead of focusing on the ones that are secondary or they're not seeking. So focus and make sure when you go in with the individual, just explain what they're using, and that's always the, tell them that, when you're advocating that, hey, this person's extremely struggling, multiple overdoses. Usually I found that pretty successful so far. So anyway, I appreciate everything that you guys do and really stand for, and thanks for helping out people who use drugs, because it's really a challenging time for not only them, but all of us and their families. And so, yeah, I'm going to stop talking before I get emotional. Thanks.
Thank you. Well, before we all get emotional, because I'm like, I'm also very close on the verge of having some tears here. So Megan, any final thoughts?
No, just really just to say thanks to everybody for coming. I think like any infectious disease, COVID-19 shines a light on sort of the greatest inequities in society. And that's really what we see is those most vulnerable, our most marginalized folks that have the hardest time. And so just really proud to be a part of this whole community of people that have worked to advocate and work together with people who use drugs, and learn so much from Guy and all of our colleagues at Van Du, and that this, what seems like something that came through very fast, actually came on the shoulders of many people that we lost, and that many people lost their lives fighting for these guidelines. And I hope as a nursing community, we can help keep them beyond this pandemic. And I know there's lots of commitment from government for that, and that hopefully we can hold feet to the fire. And in honor of Tracy, I'm thinking of Tracy and many others that are close to everyone's hearts, that we can just keep this going. Thanks, everyone.
Thank you. And Tim, I don't know if you can talk to us and share some final thoughts, or if you're still stuck with your technical issues. No. Oh, that's too bad. So I don't know if Sam, if you're still around, if you want to jump in and maybe have some closing words.
Yeah, thanks, Mary Lou, and thank you, everyone. a huge note of thanks to our panelists for sharing your insights and experiences during this really difficult time when I think a lot of nurses have been called to action in so many different ways, but also just as an extension of the amazing work you're all doing and involved in. I think we had a really rich discussion, and that's largely in part to a number of really great questions that people asked, so really appreciate those. I know we weren't able to get to everybody's question, but we will endeavor to do so in a bit of a different format. So we've been collating a number of questions we've received through these webinars about the risk mitigation guidance into a frequently asked questions document, which I think is like 30 pages at this point. So it's something that's going to be a bit iterative and we'll continue to add to. So keep an eye out on our website for that. Once it's available, I think we'll be sending the link out to everyone who's joined any of these webinars. If you have any other outstanding questions that didn't get answered about the guidance or specifically for BCCSU, please don't hesitate to contact me. As well, just I guess on behalf of Mary Lou and I and the Harm Reduction Nurses Association and BCCSU, just wanted to thank everyone so much for joining and hope you all have a lovely evening and a happy Nurses Week.
Thank you. Thanks for joining, everybody.